It's 11:11. Make a wish.
Okay. You ready?
Yeah.
Okay. Hi, and welcome back to the Hacking Hypermobility podcast, where we bend the rules to bring you the latest insights into joint hypermobility syndromes. We call ourselves the Bendy Mamas.
Yep.
So it's about time we talk about pediatric concerns.
Yeah. So today we're just going to dive right into that topic. It's close to our hearts. And let's talk about how hypermobility affects our children and teenagers and 22-year-olds.
20-somethings.
Yeah.
Our baby zebras. So it is essential to shed light on this condition early to provide the best care and support for our little bendies. So today we're going to talk about a new medical classification called Pediatric Joint Hypermobility Syndrome. This is actually going to be a two-part episode. First, today we're going to explain the pediatric diagnostic process and criteria, and then the medical research background that went into the formation of this new term. In our follow-up episode, you will get to hear from a pediatric patient who gets to talk to an older teen about their experience for a firsthand perspective. It's not often that we get to talk to our peers that relate to our health conditions, and it's not often that our kids have the opportunity either.
Yeah. So, but before we get into that, we have an announcement. We are growing, and with growing and comes expenses. And so you can actually help us cover some of those expenses by supporting us directly on our website. If you go to hackinghypermobility.com/shop, right now there's just one item there, and it's just $1 donation that you can choose to support. But pretty soon we're going to be offering items that are handmade by these disabled hands and offering them to you. So check that out. And also we're going to be offering a subscription for some bonus content, because if you think that our recordings are actually the hours that you see or hear, there's probably
there's so much more.
It's like the tip of the iceberg is what y'all get. So anyway, so that's the end of that.
And before we get started, though, just a reminder, we have that quick little disclaimer. The information provided in this podcast episode is for educational purposes only and should not be considered as medical advice. Consult with healthcare professionals for personalized guidance on managing Ehlers-Danlos syndrome or pediatric joint hypermobility syndrome.
Right. Okay. So what exactly is this pediatric joint hypermobility syndrome?
So PJHS isn't new, it's just a new term. It is a health condition characterized by increased joint flexibility in children. It was coined to incorporate children into the diagnostic framework for hypermobility conditions. So PJHS often leads to joint pain, fatigue, and even dislocations or partial dislocation.
Yeah. So from our experience, it's essential for parents and caregivers to recognize these signs early so that you can make sure that proper management and support is there for these kids. Because if you don't know, you can just be injured. I have injuries from when I was a kid doing things that if I could have prevented them, I might not be quite as
right.
Yeah.
And absolutely. And speaking of recognition, recent studies have actually looked into this particular age group and topic, and have highlighted the importance of early diagnosis and intervention.
Okay. So like the Ehlers-Danlos syndromes, does this pediatric joint hypermobility syndrome have a genetic component?
Yeah, it seems that way. Both research into the pediatrics and adolescence aspect of this is still very new, but it does seem that we've found that a lot of these patients will feed into a genetic component of this, or if there's a family history. But the key point I actually want listeners to know after listening today is that early identification of hypermobility in children can significantly improve their quality of life day to day, and improve their long-term outlook by preventing long-term complications, regardless of if it's in your family or not.
Yeah. So I think it's important to note before we go further that pediatric joint hypermobility syndrome is relatively new term, like Luna mentioned. So is this basically a clarification of the 2017 HEDS criteria?
Yeah. So in 2017, the hypermobile Ehlers-Danlos syndrome criteria was developed, and then the call to action for pediatrics came, and they had a working group to put that together. So just to kind of clarify, so if hEDS is Barbie, PGHS is her little sister Skipper, to oversimplify things. I'm sorry. Don't look at me like
That's
that.
pretty good. That's kind of like when we made the viola of manatees. We'll explain that later. Okay, so let's dive into this new pediatric framework. Okay, so before we get complicated on things, what are like the main key like the TLDR for hypermobility in kids?
So the way hypermobile children and adolescents are evaluated and managed is not very well established. However, with those recent efforts I mentioned, that came from an international coalition of experts, included the hEDS Society and other experts, and they pulled together a group starting in 2020 that has given a greater understanding of our pediatric patients. So this group is called the Action for HSD and hEDS Accurate Diagnosis, or AHEAD.
So we have heads together and AHEAD.
Yeah.
Okay.
So the AHEAD Coalition formed a group of organizations involved in the welfare of children and young people with HSD or EDS and their families. So they established this diagnostic framework for children and adolescents. And we'll go through that, and I'll touch on the research and that sort of thing. But through this effort, we have some key points that the TLDR, here it is. So the first thing, prevalence. Hypermobility is more common in children than adults. So it's estimated that up to 30% of children have some degree of joint hypermobility. And hypermobility occurs on a spectrum, and a patient's experience can range from completely asymptomatic, they don't have any issues, to a lot of symptoms that might disrupt daily life. The second thing is that there are developmental considerations because children are still growing, and that means every part of their body is growing. So hypermobility can affect our kids differently at different stages of development. And while some may experience no symptoms, others may develop symptoms. Sometimes they develop concurrently with pre-adolescence and adolescence and onset of menstruation for girls.
Mm-hmm.
They may develop things like joint pain and fatigue and pain or related issues, even in childhood and as they grow older. The third thing is that there are still challenges with diagnosis.
Yeah.
So diagnosing hypermobility in children can be challenging due to variations in joint laxity, and just the overlap of symptoms with other conditions and them not being fully developed. So a comprehensive evaluation by a healthcare professional experienced in hypermobility syndromes is essential for accurate diagnosis, but sometimes we have barriers to care to find those sorts of professionals. And the reason why it's important is because there are actually multiple causes of hypermobility, and there are several inherited connective tissue disorders that could be the cause as well. So that's my fourth point. There are associated conditions, just like with adults. It's not just joints. So children with hypermobility are also at an increased risk for developing other conditions. So they say they can develop EDS, but as we know, not really developing, it's just becoming more obvious. They're also at a greater risk for things like juvenile idiopathic arthritis or other connective tissue disorders, sometimes the onset of autoimmune disorders, pain syndromes, etc., and even autonomic issues starts younger. So really it's essential to identify a hypermobile kid so we can monitor for any additional symptoms or complications and support them. And 5, it's really important that we all get physical activity, of course, but the impact on physical activity for kids may be a little different.
Right. And to get the right kind of activity.
Exactly. So hypermobility can affect a child's participation in things like physical activities and sports. So while regular exercise is needed for all of us for just our overall health, it's essential to be able to choose um, with some informed um, information about your health and your kids' health to promote things like strength and stability and joint protection. There's certain choices we make in how we get activity as adults now that we know that we wish, like Shelli said, we
Yeah.
had known younger. And so obviously, there's other aspects of a child's life that are affected the same as us. So the sixth point is the psychosocial impact.
Yeah.
So chronic pain and limitations in a kid's physical activity can have a big impact on their psychosocial well-being. So it's essential to address not only physical symptoms, but also the emotional, the social aspects of living with hypermobility. Um, and then seven, of course, are healthcare treatment approaches. So treatment for hypermobility in children focuses generally on managing symptoms and improving function, and really setting up a foundation for a healthy, strong body to face those sorts of things as they do get more symptomatic. So this can include things like physical therapy, occupational therapy, pain management strategies, assistive devices, lifestyle modifications, and other types of specialties.
Yeah. Teaching them how to advocate for
Yeah.
themselves.
That's a big deal, letting them have a voice early and teaching them how to do that in a healthy way.
Yeah.
And then finally, the last, big key point I want you to think about is the long-term outlook. So with proper management and support, many children with hypermobility can lead active and fulfilling lives. However, it is essential to know so that we can monitor for changes in symptoms or complications over time and adjust their treatment accordingly.
That's incredible that they're taking this step. They're like looking at the bigger picture. Like,
Mhm.
this is what's happening. Here's how
I
we
remember
can.
when it was first announced, I was so excited because I
Yeah.
saw it as a big gap. So,
Getting there.
yeah,
So can you tell us more about the work being done by the organizations like the Ehlers-Danlos Society and the AHEAD Coalition?
absolutely. So, Shelly, their efforts in raising awareness and advocating for better care for our pediatric patients are really commendable, in my opinion. Like I said, I was thrilled when I found out that we were even going to be given monies and grants for these organizations to do this work. And now that the work's being done,
Yeah. And I'm
it's
glad
really
you keep an eye
encouraging.
on that because,
Yeah.
like we said before, like I don't really,
Your
that
kids are
kind of,
kind of aging
I've like
up.
dropped off of that.
Yeah.
It's really
Yeah.
weird.
So the EDS Society began this effort with an awareness event a few years ago. It was called Pediatric Concerns in EDS and HSD Exploring the Impact of Misdiagnosis. And you can watch that online, actually. It was a YouTube recording. So from there, the experts kind of gathered and said, okay, this is a bigger thing. And they formalized the AHEAD Coalition with the Pediatric Working Group for the International Consortium. So this group is a group of international experts, and they met online because this was started in
Pandemic.
2020.
Yeah.
And they shared both their real world clinical experiences and evidence based medical research and pulled it all together. They made some important changes to how younger hypermobile people are evaluated and diagnosed. So, after a few years of this, the group published their findings last year in May of 2023,
Okay.
establishing this new approach. In the article that was published titled Pediatric Joint Hypermobility, a Diagnostic Framework and Narrative Review. I'll put a link in the show notes because we're clearly not going to go over every single
Yeah.
little detail of the full report if you're interested, though.
All right. So, okay, full report's long, lots of information. Can you give us the key changes that
Yeah.
parents might want to be on the
So
lookout?
the key difference is
Or the
that they
differences,
drew
yeah.
a line separating the diagnosis based on age
Oh,
and biological maturity.
okay.
So the study introduced a novel diagnostic process and changes how we evaluate.
Okay.
That emphasizes a multi-dimensional evaluation of joint hypermobility in children. So it looks at different things, more of a bigger picture.
So is hEDS an adults only now? Like, what about people who have been diagnosed with hEDS, like children? Is that gone?
So they're not going around yanking diagnoses, but yeah, hEDS is now considered an adult diagnosis or biological mature diagnosis.
Okay.
And there have been some criticisms from within the community about gatekeeping
Yeah.
hEDS or hypermobile EDS with the establishment of this pediatric framework. However, based on those changes that they made.
So this was part of a big, large study of experts in the field, yeah?
Yeah, this was
Okay.
a very large study based on their findings in a large literature review. So taking a bunch of
Oh,
studies, putting them
yeah,
together,
okay.
aggregating data, as well as their own clinical practice. So in the article, the group stated, quote, children have high levels of joint hypermobility. Herewith, they call it just hypermobility, making it difficult to diagnose those those with a normal physical trait from those with an underlying disorder. So hypermobility decreases during pediatric years, probably later in adolescent females than males. So basically, they're saying children don't have a stable phenotype. The group proposed that we wait until maturity to diagnose hEDS.
Okay. So it's a placeholder then, right? Like a child can be like it's like a transitional, like you're going to get PJHS, and if then after you've reached a certain age, they'll reevaluate you and maybe get a hEDS diagnosis.
Yeah, so it's not really like a placeholder, like here's your designation, come back in 5 years. We're going to have to make that effort, but they consider it a fluid diagnosis. So this brings me to the
as if we're not confusing enough.
right.
Okay.
So this does bring me to the other criticism. So this adds a step in care and diagnosis when it's already such a struggle to get
I
an
didn't even think about
appointment
that part.
with a specialist confident in diagnosing hEDS and the other connective tissue disorders that are inherited. So there are concerns with access to qualified diagnosticians and then just the added financial burden. Essentially, if you're a hypermobile kid now without an established family history, you'll have to go through the diagnostic process twice unless they see like clinical indications of like say Low-H's or some other inherited connective tissue disorder. And despite it being genetic, it isn't that common for family history to be established of hEDS. So
Yeah, because all of my
diagnosis
history looked like VEDS,
yeah.
but I got diagnosed with hEDS. So what is the positive aspect of this?
So, well, primarily it is establishing a standard to even identify these kids
I mean, yeah,
that need medical support. But also, I do see the benefit of casting a wider net, essentially, to diagnose and treat kids with generalized hypermobility sooner rather than later. And that was my big complaint, is that we weren't even considering kids. They weren't even being checked or evaluated.
Yeah.
So now, so the wider net is, okay, well, we may diagnose a bunch of kids with pediatric joint hypermobility, but some of them will, quote, grow out of it. And then some of them, as they continue and progress, then we're going to need to say,
is the grow out of it really a lie, though? Because
so in their research, there truly are kids that are hypermobile as children, and they aren't as hypermobile as they grow up.
Because I keep hearing stories about how when you get older, you get less bendy, and I'm still a 7 out of 9.
Yeah, and they're talking about like they're 7 and 8 and very bendy, and then by the time they're like 10,
oh, okay, so then
developed muscle tone,
kind of like the general kid floppiness as a protective measure,
right? So that's kind of the idea.
Gotcha.
Like we're just being more careful.
Okay.
So some of these kids might get appropriate care, and then their issues might resolve as they mature. But others may remain significantly symptomatic as they mature and need future workup. So in some ways, this is more inclusive and proactive. Um, I don't know that it's the perfect solution, obviously, but it's a really great first step. And I will say that they used a very large data set with over 5,000 pediatric patients between all of them.
Okay.
So they did explain the reasoning to how they came to these changes this way in the article. Quote, the diagnoses are fluid, allowing children with generalized joint hypermobility, GJH, to be reclassified over time as typical if GJH resolves, asymptomatic GJH symptom as symptoms improve, or pediatric generalized HSD. And they've abbreviated it PJHSD upon presentation of new signs and symptoms. An accurate PJHSD diagnosis provides the foundation for appropriate current treatment and support, but not a lifelong diagnosis, which may result in over-medicalization and potential harms. The framework supports identifying those with hypermobility as a physical trait, which is relatively common, those with musculoskeletal issues related to the hypermobility, and those who may develop the rarer hypermobile Ehlers-Danlos syndrome as they mature. So, and that's based on a large data set. So this framework will support targeted genetic testing, which currently has a 11.5% yield, and improve consistency when researching epidemiology, symptom evaluation, complications, and interventions. So I think their article explains it, succinctly.
Yeah.
But I'll let Shelli read the conclusion so we kind of have a inclusive statement here.
Okay. All right. So the experts summarize their work of 2 years establishing pediatric joint hypermobility syndrome with the conclusion that this framework allows hypermobile children to be categorized into a group describing their phenotypic and symptomatic presentation. It clarifies the recommendation that comorbidities should be defined using their current internationally accepted frameworks, and that this provides a foundation for improving clinical care and research quality in this population. Okay, so while there are criticisms, the changes are a significant step toward ensuring accurate and timely diagnosis so we can get the timely intervention for these baby Zeebs.
Yeah, absolutely, Shelli. So, and I'm sorry I made you read medical research.
That's
but
fine.
You did great. But what's
My mouth and eyes and brain are
she's
sort
like,
of working.
okay, let me just take a break now.
Blah, 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 blah. Yeah.
But what's particularly exciting in this, despite those criticisms, is the emphasis on functional impairments. They looked at that, which acknowledges the impact of hypermobility in a child's daily life.
Well, that I think is really, really important because if you consider the functional impairments, then healthcare providers can better identify the unique challenges faced by each kid and provide tailored support to improve their overall well-being and connect our children to the appropriate specialists and interventions. So that's good.
Yeah, precisely. So the new diagnosis process is not perfect. And I expect it will change as we flesh out the genetic understanding of things like hEDS and maybe even further subtypes. But this really represents a paradigm shift in how we approach pediatric joint hypermobility syndrome, focusing not just on joint flexibility, but a broader clinical picture.
Right. And with increased awareness and adoption of this comprehensive approach, we can ensure that every hypermobile human receives the care and support early enough for all of us to thrive.
Absolutely,
Yeah.
sure. That's why we do what we do. So it does feel like a step in the right direction. It's an
Yeah.
exciting time for pediatric hypermobility, and we can't wait to see how the new diagnostic process improves outcomes for kids around the world.
Yeah. So let's dive into this diagnostic process. How do they evaluate pediatric joint hypermobility syndrome?
Well, remember I told you they look at things beyond just the joints.
Okay.
So pediatric hypermobility takes several aspects into account. The generalized joint hypermobility, the skin and tissue abnormalities,
Okay.
musculoskeletal complications, the core comorbidities, and if the patient is symptomatic.
Okay. So will they do any genetic sequencing for this
So
or?
generally, they don't recommend genetic panels, but importantly, it's still diagnosis of exclusion. So PGHSD is used after doctors clinically evaluate a child and rule out other medical reasons for hypermobility, including the Ehlers-Danlos syndrome types, the other inherited connective tissue disorders, syndromic conditions, chromosomal microdeletions, skeletal dysplasia, neuromuscular disorders. There's multiple causes. So if you have a hypermobile child that you still need to be assessed for the risk of an alternate diagnosis, get them investigated appropriately. Diagnosis is generally based on a clinical exam and family history if available. But if there are concerns, genetic testing might be indicated. So the consortium came to the conclusion that they don't recommend genetic testing on all children with generalized joint hypermobility or HSD or hEDS because they can clinically diagnose it. Once the hEDS gene is established, that would be part of the exclusions, obviously. And once we have genetic testing to diagnose hEDS, that particularly family history would bypass that flow.
So is there like a checklist, like a form, like the hEDS diagnostic checklist we shared in last season?
Yeah, so there is now a checklist for the PGHSD evaluation. It's very similar to the hEDS checklist. I'll put a link in the show notes for your reference if you're planning to have your child evaluated. It's a great tool to look at ahead of time to kind of know and have your ducks in a row.
Yeah. And I would also recommend you have your ducks in a row, but make sure whatever physician you're going to evaluate your child can be prepared. So it's like you prepare yourself and make sure you feel like your physician will be able to help you. So Luna, can you break down what worksheet they use and
Yeah.
like what you might need to think about?
So this worksheet is just a one-page sheeter, and it goes through the main points that I mentioned before. It breaks them down through like an algorithm. So it's a workflow through these aspects that the doctors examine. It's not complicated, so we'll go through it with you.
Okay.
Shelly, if you look on your screen, I
Yeah.
have it broken down for you.
Yep.
You can look as we go through it.
Yep.
So first at the top of the worksheet, they start the algorithm based on, of course, age.
Yeah.
So at the very top, it says children from 5 years of age until biological maturity. So that's who this is for.
Okay. Yeah. So then it looks like Byton right there.
Yeah. So the first section is just the traditional Byton score.
Okay.
And so it measures, of course, your extensibility of your pinkies, your thumbs, your elbows, your knees, and then bending over, touching the floor, and points for each side of the body.
Okay. So
the
still not taking in any other.
No, it's still the traditional Byton score.
Okay.
And so there's 9 points, and they consider them generalized joint hypermobility and move forward through this worksheet if they score a 6 or above, so
Okay.
6 out of 9.
Okay.
So they're using the same joints, same scoring as hEDS.
Okay.
But a positive score is at least 6 of 9.
Okay. So then next we move on to like the skin and tissue concerns. So what are those abnormalities? Is that the same too as?
So yeah, kind of the same ones. So again, this is scored. So it's just a little list that you check off, and it has to be a minimum of 3 of 6 of these. So at least half. So I'll read through these. Unusually soft skin, the softer velvety skin.
Yeah.
Mild skin extensibility.
We got some right here. Want to see that? All right.
Unexplained striae rubeae stretch marks at the back, groin, thighs, breast, or abdomen without a history of significant weight gain or loss of body fat.
Okay.
And like I've seen that in my child. Like, and I remember
Carolyn has them.
Yeah, and I remember getting them and being really self-conscious of them. Yeah. But it's just interesting because I didn't have the perspective we have now of watching it develop, and now I see it. I'm like, oh.
Yeah.
The fourth one is atrophic scarring involving at least one site.
There's a finch at the window.
A finch?
It's a house finch.
Oh.
Anyway, sorry.
What color is it?
It's a female. She's pretty boring looking.
She's pretty boring.
Yeah. Sorry. Continue.
We like birds here. Okay, so atrophic scarring is the fourth one.
Yeah. I mean, this one here, it's faded, but I've had this is like a almost a 40-year-old scar,
Mhm.
but it's
You
still
can see the, like,
raised. It's
the
still raised
weird
up. Yeah.
pattern. Without the formation of truly peppersias, which is the papery thin, or hematosideric scars as seen in classical EDS. So if they see different kind of scarring, then they might want to evaluate you genetically for things like classical light, that sort of thing.
Okay.
And then the fifth one is bilateral pisogenic papules in the heel. Those are those little bubbles that you see when you put pressure standing on your heels. Um, and then the last one is recurrent hernia or hernia in more than one site, excluding congenital umbilical hernias.
Okay.
Okay, so now keep in mind, any of these things just on their own just kind of sometimes happen.
Yeah.
So the point is, this is a cluster of symptoms and it's a stack of them.
Okay.
So we were already talking about this is a pretty hypermobile kid. They've scored at least a 6 out of 9 on the bite.
Yeah.
And then if they meet at least 3 of those, then we have some
There's some.
notable tissue abnormalities. It's not just 1 or 2 things.
All right. So let's move on to the musculoskeletal. So section 3 has a score for the possible musculoskeletal complications. What are those?
So for us to score positive in this section, you would need 2 out of 3 of these.
Okay.
So the first one is episodic activity-related pain, not meeting the chronic pain frequency and duration criteria.
Okay.
Recurrent joint dislocations or subluxations in the absence of trauma and or frank joint subluxation on physical exam in more than one joint, excluding the radial head, and less than 2 years. Soft tissue injuries, one major meaning needing surgical repair and or multiple minor tendon and or ligament tears. So again, they're looking at different aspects, not just the joints. We're looking at these soft tissues that are holding together our joints and also just generalized pain too.
Right. And so you said to have 2 out of 3 of those.
Mhm.
Okay. So they're looking at comorbidities also. The final section, section 4, has the comorbidities that are identified along with if they are causing disability. And what are those?
Okay. So the disabilities they identified as the comorbidities that are pertinent to this diagnosis are chronic primary pain,
Okay.
chronic fatigue, functional GI, gastrointestinal disorders, functional bladder disorders, primary dysautonomia, things like POTS, and anxiety.
Okay. Wow. And it just says that's just yes or no. There's
Just
no
yes or no.
minimum. Okay.
Yeah.
As long as one of those are checked, they're like, all right.
Yep.
Okay. So what can a parent do? So it's easy to get hung up on the changes and be like, it was already so hard. It's harder now. But like, let's not overlook the importance of parental support and education. So websites like Ehlers-Danlos Support UK and the EDS Society offer valuable resources and guidance for parents navigating their child's journey with EDS and HSD and PGHSD, XYZ,
All the
elemental P,
alphabets.
blah, blah. Did I get all the letters?
Yeah, I think we got them all.
Cool.
Maybe some extras. Well said, though, Shelli.
Thanks.
So additionally, there are online forums and even Facebook groups intended for parents. It's essential for parents to equip themselves with knowledge and support to advocate effectively for their children's needs and just to have as a resource and social support.
Yeah.
And as a reminder, hypermobility conditions are very common with things like ADHD and the autism spectrum disorder and other types of neurodivergencies. So it's important to mention if your child shows any signs of different neurotypes, so we can get them evaluated and get them appropriate support also.
Right. And so one big thing that I think a lot of people have overlooked, and I made that connection once I got diagnosed hypermobile. One of the questions when my children were being evaluated for autism was they asked the question about W sitting, right? And I find it not hilarious, but kind of interesting that W sitting is not included anywhere on this child.
No.
It's almost like they don't want it to be associated with, because that was very explicitly asked to me about W sitting at my son's.
And that was, remember when we talked about our criticisms of the hEDS diagnostic
Yeah.
criteria, and the criticism of still using the Beighton score was, you know, it doesn't acknowledge hypermobile hips.
Yeah.
But things like hip dysplasias are seen in some more serious subtypes of EDS. So
Yeah. Well, so
really
that's really
look at-
making me wonder if I have a more serious subtype. So, all right. Let's wrap it up then.
That's
So, overall, early recognition, accurate diagnosis, comprehensive care, all of that's crucial for supporting children and adolescents with hypermobility and promoting their health and well-being. So, the medical community has made strides in these changes for our younger people, but it's not quite ideal yet. And we got to get society to embrace these changes too.
Yeah, well put, Bendy Mama.
Thanks.
And all right, before we go, I want to remind our listeners to visit our website. It's hackinghypermobility.com. And there you can find resources, links to our socials. But also, we have that new support option available. So please consider donating to support future episodes. Small increments, big increments,
Yeah.
doesn't matter. You can just plug in your number there.
Yeah.
Every little bit helps to continue to bend the rules and bring you more valuable insights into the hypermobility syndromes.
Yes. And we have seen an uptick in people thanking us on various social media platforms that are kind of outside of the ones that we're normally on. So that's awesome that we're getting that
Mhm.
recognition. But if you see us out there like that, also take a minute to like go to our socials or even just share on your pages. I mean, I don't see everybody who says a good thing, but like
Yeah.
there's just been an uptick lately and it's so exciting. So
Yeah.
take that minute and leave us a review, give us the appropriate stars that you see fit. And if you could subscribe also, we're getting ready to unlock new side quests on the various platforms where we are publishing our podcasts based on our listens and other analytics.
So, good point. Like, we are entirely self done. Like,
Yeah.
so, we're learning as we go. It takes a lot of time. So, you would be paying not just for like our costs and expenses, but also our time and encourage us to keep researching and writing and keep banging our heads against the wall with annoying technology and that sort of thing. But also, we would like you to engage with what topics we discuss and that sort of thing. So, if anything today sparked any ideas, or you have questions or things you want to hear us discuss, please send us a message to our email, info@hackinghypermobility.com, or tag us on the socials. If you want to record something and give us permission to use your voice or your likeness or video or whatever, send that to us as well. We'd love to do that.
Yeah. And a reminder of our disclaimer, the information provided in this podcast episode is for educational purposes only and not be considered as medical advice. Consult with your trusted healthcare professionals or personalized guidance on managing the Ehlers-Danlos syndromes and associated friends. Yes.
Excuse our invitation.
Yeah.
Thank you so much for listening today to the Hacking Hypermobility podcast. We do appreciate it.
Yeah.
Till next time, stay connected.
Wishing you healthy hypermobility.
Bye.
Bye.
Good job.
Thank you.
See, that was totally worth it.
Let me turn off the recording.